Hello, everybody. My name is Janelle Shear. I'm a program manager at Stratis Health, and I'd like to welcome you on behalf of Stratis Health today for this webinar. Stratis Health is a quality and safety organization, and we're based in Minnesota. Beside me is Jody Winters. She's going to be monitoring the chat. Jody's the one that sent out the invite, so she's been helping all along for this webinar. And Jody put a question in the chat, which is, please indicate the state you're from and the type of organization that you work with. If you're not familiar with Zoom, it's a web-based platform. Each person can manage how it looks for yourself. I guess I'd recommend, so there will be a toolbar hovering at the top or at the bottom, kind of depending. And for view, I probably recommend speaker view, because then when the person that's talking, typically their picture will light up in yellow. And for audio, we're requesting that everyone not speaking put themselves on mute. So if you're on the phone, put yourself on mute. If you're just on the computer, and you can find that by clicking on the microphone icon, which is typically at the lower bottom unless your toolbar has moved to the top. For those of you on the computer, we're going to be using the chat feature for our questions and comments. And again, if you hover on your toolbar and look at under More, there will be chat, and then it will be on your screen. And I believe there might be a few people that are only on the phone, so when it comes time for questions and answers, we'll just have you unmute at that point. Stratis Health has worked with rural communities in Minnesota and beyond for over a decade in starting and strengthening community-centric palliative care programs. We've coached and assisted 24 rural communities in 3 cohorts in Minnesota. In 2017, we expanded this work into 3 additional states, North Dakota, Washington, and Wisconsin, who are working with a local partner organizations to support 5 to 7 communities in each of these states. So welcome all of you on the call.
So,
as a result of, so please keep your phone on mute. As a result of our work over the past decade, we found that rural communities can provide palliative care services effectively. One of the biggest challenges for these communities is how to sustain the program financially. Our educational session today is Sustainability Strategies for Rural Community-Based Palliative Care. Carla Wing, my colleague from Stratis Health, will start the presentation with some background information, and then we'll hear from panelists from 2 rural health systems about their journey on sustaining their palliative care programs. Before I introduce Carla, let me mention how to get a certificate of participation after the webinar that can be used for continuing education credit.
I was muted by the way.
Camera on?
After the presentation, anyone that registered will receive an email from Jody Winters with a link to a short evaluation survey. Please complete that, and once you've completed it, a certificate will pop up for you to print off. If there are others with you today under your registration, please forward the email to them. We're also going to put the evaluation link in the chat, so if you want to just go right to it at the end, you can do that as well. So now I'll introduce our first speaker. Carla Wing is a Senior Program Manager for Stratis Health Rural Focus Programs. She provides expertise and support for rural initiatives at both a local and national level. Carla and I have worked together on rural palliative care initiatives since they were started back in 2008. You can read her full bio and the other speaker bio in the document that Jody sent in the invite. Carla, I'll turn it over to you now.
All right, thanks, Janelle. So Janelle gave a nice kind of background and highlight about what we're going to talk about today. We are really going to focus in sort of on the financing piece of palliative care, particularly some of the opportunities and challenges for rural community-based palliative care programs. So I'm going to provide sort of some big picture background, share with you a framework that we put together we released it earlier this summer based on learnings that we've gathered from a variety of folks, including some roundtable discussions. And then I'm going to turn it over to the folks from Avera Medical Group and Walia Health are going to share their individual journey. So you'll get big picture from me and then actually get a specific stories from the 2 organizations that are on and willing to share with us today. So next slide. So Stratis Health, just briefly some context. We are an independent nonprofit organization. We are based in Minnesota, although we do a fair amount of work, particularly in rural and long-term care areas, both regionally and nationally. Our focus is on leading collaboration and innovation in healthcare quality and safety. We do a lot of facilitation and improvement, both for organizations, people, and communities. So really focus on supporting improvement initiatives across the continuum of care, where palliative care fits in very nicely. We're primarily funded by government contracts and private grants, and we like to say that we work at the intersection of research, policy, and practice. We don't really do any of those three things, but we help connect the dots. We help folks in practice understand the research and the policy, and we help the folks who are doing research and policy understand practice. So really sit in the middle of that. We do have rural health and serious illness care kind of as long-standing organizational priorities. And as Janelle mentioned, we've been working both in Minnesota and now with some partner states in Washington, Wisconsin, and North Dakota in particular. And through that scope have been able to work with more than 40 communities focused on this palliative care effort. Next slide. Just some level setting. I'm guessing if you're on this call, you're familiar what palliative care is, but wanted to make sure we were on the same page when we were talking about it. It really is specialized medical care for people with serious illness that focuses on relieving symptoms, pain, and stress. It can be appropriate at any age and at any stage, and together with curative treatment. So as we're talking about the reimbursement and financing piece here, we're really not talking about the hospice aspect of palliative care. So as we usually talk, when we talk about that together, we usually talk about palliative care being a big circle and hospice being a part of palliative care. So it is one type of palliative care. So we're really talking more broadly than that when we're talking about the sustainability strategies here. So really the goal is improving quality of life for the patient and their family or caregivers, and that it's an interdisciplinary effort that works with the patient's other providers and physicians to provide an extra layer of support. Next slide. So essentially, the pillars of palliative care: pain and symptom management, psychosocial and spiritual support, both for the patient and their family and caregivers, and information and support to make decisions that reflect the goals and values of the patient, while focusing in sort of on the continuity of the care plan and connecting the patient and family to resources, either medical or more broadly into the community. Next slide. So when we talk about palliative care in a rural context, there really is, in most communities, a fairly significant need. I spend most of my time focused in the rural health kind of arena, and there's a saying we like to use that essentially rural communities tend to be older, sicker, and poorer. So when you're thinking about the needs of folks with serious illness, a lot of them do fall in those buckets, and typically we have more health issues as we age, and that when we're sicker and poorer, that just can kind of compound the needs that we might have in terms of having challenges managing care. There are also some unique challenges in rural. Certainly there is a limited availability of board-certified palliative care clinicians. I would say that is globally true, but even more so in rural communities. And then essentially there really is just chronic workforce challenges in most rural communities as well. I'm not sure that I have ever talked to any rural healthcare providers who have more than enough staff and don't have any open positions. So typically that's an ongoing challenge in most rural organizations that provide services. There's also really a lack of research and models that are specific for rural care delivery. Certainly Stratis Health has been doing work and trying to do some of that. There's a fair amount of work in California, been some work in North Carolina, but really most of the clinical models that have been developed are really, they started in large tertiary care hospitals, and kind of the spread out of them to more community-based settings has really been predominantly in more urban settings. So that's where most of the research and the models sit. And then we're going to talk a little bit more in detail about some of the unique challenges in reimbursement and financing for palliative care because of the way that most rural healthcare organizations are structured. So what we've done with Stratis Health is we have something called a community capacity-focused formula for program development, where we've worked with rural communities to help design palliative care programs. So we don't come in and say you need an FTE to do this and you need a chaplain to do this. We really help rural communities identify what are their data and goals, get broad stakeholder input, provide some of that access and translation and support around national standards and resources, and then ideally support through a facilitated planning process, getting those communities to have an action plan and a program essentially that develops out of that action plan that aligns both with their unique needs and their unique resources and capacities that they have available. So that in some ways I think we think that's the most appropriate way to do this in rural communities, because I think it allows for some creativity, but it also really kind of increases some of the challenges in terms of financing, because you're talking about a wide variety of what programs might look like. So on the next slide, we kind of highlight there that we've seen lots of rural communities set up palliative care programs and do really great work in this area, but there's really wide variation in structure and focus for formal programs. There's a lot of focus on advanced care directives, process for goals and care discussions, shared order sets, and care plans connecting across settings. Lots of folks do incorporate professional and community education. So lots of different pieces and parts, but when you're talking about looking at reimbursement for those, that makes it even more challenging to say, here's the way you get reimbursed, because everybody's program looks a little different and they have different avenues and opportunities for financial support. So just some examples on the next slide are really some of the variables in program structure that we've seen in rural communities. So pretty wide variance in terms of service delivery, kind of who's on the interdisciplinary team. All the teams that we're aware of really do have at least that physician, social work, and nursing component, but then the other disciplines can vary pretty widely. How they wear folks, what patient populations they focus on can vary widely, and sometimes varies over time depending on resources. And then we also see lots of different folks sitting sort of in that coordinating role, that star role that kind of helps make the rest of the team go around. So pretty wide variation in terms of programs, because communities are setting up programs that align with the resources they have available to them. So with that sort of background around what it looks like, just wanted to highlight briefly some of the specific financial challenges in terms of rural programs. Again, in most rural communities, the predominant payers are Medicare and Medicaid. We have seen that a lot of times some of your Medicare Advantage or your commercial plans have been a little bit more progressive regarding opportunities for reimbursement related to palliative care type services. But we don't have as much penetration typically of those. In Medicare Advantage penetration, there's only about 24% in rural communities compared to 34% overall. Again, that varies widely by state. And then the other thing that we see is, even if you have Medicare Advantage or that you have HMO or health plan around Medicaid, typically most rural healthcare organizations have pretty low volumes, and that really can limit their negotiating power with private plans. So you don't have the same ability as perhaps some of the larger healthcare organizations to go to a payer and say, hey, we have this great program. These are the things we think we can do for you. They might think that's great and may be interested, but if your volumes are fairly low for any specific payer, then a lot of times they're just not willing to have those discussions with you. The other piece that is both, I think, a benefit and a challenge is that really the underlying payment mechanisms for most rural healthcare organizations are different, at least from a Medicare standpoint. So you see a lot of critical access hospitals, federally designated rural health clinics, and federally qualified health care centers, so CAHs, RHCs, and FQHCs. And what we see with those safety net programs is that they're reimbursement types, so they're able to get additional or different types of reimbursement to help stabilize care in those settings. But that also means that then they're typically exempt from the value-based reimbursement programs that Medicare has set up. So, for example, Some palliative care programs have highlighted their ability to support readmissions reductions. So if I'm a larger hospital, I get a penalty if my readmissions are too high. So critical access hospitals aren't impacted by that. It's not a factor. And then we see that with some of the other payment programs. There's some newer payment programs coming out as well. And essentially, because they already get paid differently, and a lot of the Medicare value-based programs are built on the current reimbursement systems, that critical access hospitals, rural health clinics, and SQHCs aren't eligible or are exempt from them, which may be a benefit in some situations, but in terms of trying to strategize in where palliative care fits into those value-based programs can be a challenge. And then finally, we can't really talk about rural healthcare organizations, particularly hospitals, without highlighting that there is really a lot of financial vulnerability right now. There's been 119 rural hospital closures in the country since 2010. And then depending on which way you look at the data, there's anywhere between 400 and probably 600 to 700 critical access hospitals in particular that are considered at financial risk for closure. So lots of financial challenges, and I think a lot of times hard to invest in additional programs when you're really focused on trying to keep the lights on in your organization. So that's some of the challenges. But we've actually found in the next slide, I just want to give you a little background of what we found, how we gathered the information, because certainly we know that lots of rural communities are doing this. So we had an opportunity about a year ago. We held 2 roundtable discussions with rural palliative care programs, primarily here in Minnesota, but we also had some folks from surrounding states, and really just were able to spend an afternoon or a morning with folks really just talking through kind of what does your program look like and what is your business case for it, what is your financial sustainability strategies related to that. We also did several key informant interviews. We did some literature and web searching. We were fortunate to have a graduate student, Lauren Soltide, working with us, who did a lot of the background work, and it was great to have her support and perspective. And then once we put together an initial kind of framework, we got feedback from our Minnesota Rural Palliative Care Advisory Group and a variety of other partners. So we feel like the model that I'm going to share with you now has been fairly well vetted, although I think it's going to be changing kind of in an ongoing basis. So the next slide is really kind of the meat of what I wanted to share with you. If it's small on your screen, we actually do have a full resource guide with lots more information in it. The link there is at the bottom. And this is really when we talked with rural programs and a variety of other folks, this is what we identified as sort of the strategies for sustaining a rural palliative care program. And I'm going to start at the bottom because it is the one thing that we really heard across the board, and that is that folks who are able to get these programs up and running and continue to sustain them have really just decided that there is really important underlying value in having this service available. It's just the right thing to do. It improves quality of care, improves quality of life, and is just a better way to provide care, ensure that that care is provided well in their communities. So really that underlying value has been a key component that we heard from everyone that we talked to about their strategies for sustainability. From there, it was really a pretty wide mix of what we heard from folks. So it wasn't really any one strategy for most organizations. There was a mix of kind of billing and traditional reimbursement, which is in blue there if you have the slides in front of you. And that is that you can do billing for your provider visits. So folks were doing that when possible, that they can do Medicare care coordination codes, so your advanced care planning, your chronic complex care management, and your transition care management. So those are the Medicare codes. Different states also have some different programs depending on your state environment. So those are kind of direct billing. And then we also see some alignment with other services, which is more kind of in the traditional realm. We see some organizations incorporate palliative care as a supportive aspect of their home care services for patients that are appropriate. And then if folks have a hospice affiliated with them, we also see the potential for earlier hospice admissions. Oftentimes when folks are in palliative care, they might make that hospice decision earlier than if that service is not available, and then that can help support your hospice. So from a purely kind of billing and financial standpoint, can be a financial benefit as well, despite the benefits to the patients there as well. The other piece that we saw folks heard about was that a fair amount of grants and philanthropy, and this looked different depending on the organization. You know, we did talk with one program who is entirely funded by a grant. They had a large bequest that said, we want you to use this to provide palliative care in our community. That's typically not a sustainable or a spreadable model, so we haven't highlighted that one a whole lot of places, but it is certainly an aspect. Some folks get funding from local foundations or auxiliary type things to help offset costs. And we also see folks get sort of one-time grants that might be typically used to fund development costs as well. So that's sort of the grants and philanthropy angle. And then the third area we see a fair amount of is trying to figure out and understand sort of what is that value equation for palliative care. So if your organization is part of an accountable care organization or a bundled payment program or other sort of population-based or risk-sharing arrangement where there is either shared savings or there is incentive to be reducing overall costs of care and improving quality, then understanding how kind of the aspects of palliative care related to patient goals and active care planning can help reduce potentially avoidable utilization and generate savings that might be able to be reinvested in those services is an important aspect. So that can be another angle that folks look at when they think about how do I make a business case for this service line besides the fact that we know it has underlying value, how do we try to attach some dollars and cents to it, which can be challenging. The fourth area that we identified that is really kind of shifting and changing on a regular basis is that we think there really is some emerging opportunities, either with Medicaid programs, Medicare Advantage plans, or other payers that are developing palliative care reimbursement or benefit options. And this really varies pretty widely by the state and marketplace that you're in. California, for example, has really been a leader in structuring Medicaid payment for palliative care programs. At the federal level, folks are pretty excited in the kind of the palliative care area, pretty excited about the primary care for serious illness population option, which has just been released. They're just starting to take applications for that. It's available in 26 geographic regions. Some of them are rural. That one does have the caveat that if you're a rural health clinic or an FQHC, you're not eligible to participate. So I think we're going to continue to see more exploration both from Medicare and other payers in terms of kind of emerging opportunities that might help support and sustain palliative care programs. If I'm in a rural environment, what we're really encouraging is that folks advocate for development of those reimbursement options that are similar or in alignment across a variety of payers and programs, because I think that's the other challenge. If you have multiple payers and payer A has a program, that's great, but are you able to jump through the hoops that they need for the handful of patients you might have under their coverage if it's completely different than payer B? So the more alignment we can have, and that's really an advocacy role across sort of those reimbursement options, the more likely rural programs are going to be able to take advantage of those. So that is really kind of the big picture of what we heard. Some key observations that we hear, really the lack of reimbursement for palliative care services is a significant barrier both for development and sustainability. So just want to recognize that up front. Although I think folks really are recognizing that, there are some direct billing opportunities available. If you haven't already, we encourage you to consider engaging billing and coding staff as part of your team, or at least have some discussions with them about whether or not there might be some opportunities. It may not entirely support your activities, but it might offset some of those costs. And then we do also think that the value-based contracting, even though it varies widely across states and payers, there's certainly some business case opportunities there, and that environment continues to change. So encourage people to be thinking about how do they assess that, how do they collect data and understand what's important related to cost, quality, kind of readmission satisfaction. How are you assessing those types of things? So if the opportunities are there, you can show the value of your program to participate in them. So that was sort of a whirlwind through that information, and I'm going to turn it back to Janelle.
Thanks so much, Carla. Appreciate it. Our next Presenters on the panel are from Wellia Health. We have Jennifer Peterson and Jenny Friday here today. And let me just like to introduce them. Jen Peterson is a social services director at Wellia Health, and Wellia Health was formerly known as First Light Health System. She's been there for 20 years to help change the landscape of care in the rural facility. Jenny is a nurse care coordinator and educator. She has vast clinical experience and is finishing up her master's in nursing leadership with an education focus in 10 days on December 15th. So thank you, Jen and Jenny, for being here today and sharing your community story.
Of course. Thanks for having us. Jenny and I are in 2 different locations today, so we have a plan that I hope I remember correctly, Jen. I'm going to start off just with I'll do a tiny bit of background. I think we both become pretty passionate about this discussion because when we started, it looked so different than what we're doing right now. I think it's been about 10 years that we've been working through what palliative care can look like at a place like Wellia Health. So when we started small. We started with primary providers. We have a social worker, the primary providers. We brought pharmacy in right away, and that was using our primary care teams. So our provider is basically referring patients to us who they felt needed that extra level of care for managing chronic illness. When we first started, it was slow growth, and sometimes it felt like Jenny and I and a pharmacist and the provider and the patient and their family. But since then, we've really changed. It's really become a robust program at Wellia. We now call them care teams. So very much of the way that we started is the same, but the progression has been, when we look backwards at it, it's been really exciting. So next slide. We provide service to anyone we have 3 clinic locations, one in Mora, one in Hinckley, and one in Pine City. Our satellite locations are smaller than the one in Mora. I would say numbers, but maybe Jenny can back me up when she starts talking. We see patients in our outpatient services. We see patients in our emergency room. We do consults in our hospital, and we also see our clinic patients. So anywhere in the health system, referrals can come from any corner of the health system. Those referrals have become a more streamlined process than when we first started. Now, I would say that the culture took a while to come along, but now when people say care teams, they know what we're talking about. We're talking about patients that are struggling with chronic illness and need added support. So I would say that we can probably reach almost everyone with this service at this point. The growth has been phenomenal, and the adoption of this program has been great. You can advance the slide.
All right, so this is, yep, I'm next. This is Jenny Friday. Is there feedback, or is that just what I'm hearing? Maybe it's okay.
I think it's okay.
So Jen kind of talks about the patients that we see, and we primarily focus on chronic illness, utilizing the chronic care management codes from Medicare. And so that's kind of our big focus of where we do that. Also, she'll talk about our healthcare home, but our care teams really focus on those patients that need more of that one-to-one care coordination. They need someone to kind of help them through the journey. And so we kind of start out with the chronic care management care team for patients, and then for those that look as though they're kind of within about 2 years of their life, they're struggling to manage care, they're looking for more resources to support their care at home or in the living situation that they're at. They're frequent utilizers of the healthcare system, so they're coming in a lot, or they're utilizing the emergency room a lot, and just haven't been able to kind of get a maintenance of their chronic illness. And then, of course, all the different social determinants of health as well. So housing, services, mental health concerns, vulnerable adults, history of addiction. So kind of a variety of those. Then we would look at palliative care as we look at it as an addition to the chronic care management, and I can explain that in the next slide. So initially, patients will be referred to us from the referral sources that Jen talked about. The only thing that I think we forgot to add on there for referral sources is that a lot of our community partners also are aware of the services that we're providing. And so we often, especially from our home care locally right here in town, they'll have mutual patients of ours, and they'll either tell the patients to talk to us about the care team, or they'll call and say, hey, I really think this person needs your care team, especially when they're going off of their Medicare services and are going to be at home alone with nothing. So I think that's been a great bridge that we've been able to build. But our patients are referred, and we set up the initial consultation through a clinic visit with our provider team. So all of the provider stuff is similar. So they get the rooming, they have the provider's nurse comes in, the provider comes into the meeting, and then there's the care team nurse, the care team social worker, and then if we're doing a palliative care open, then we utilize our pharmacist as well. Subsequent visits, once they're kind of on the team, they have a 24-hour phone number that they can call and connect with us. And then we try to see them on site here if they're in the clinic or within the facility and want to visit with us. We kind of set that plan as per their choice. And that's similar to how we follow up with them on the phone. At a minimum, we follow up with them or seek them out every month. But truly our goal is to build that relationship so that when they're in crisis or when there's even just an itty bit of change, they're calling us and seeking that out. And I would say that definitely grows with the time that you're with them. They just kind of get that relationship, and that rapport building is so valuable in the beginning. So next slide. So how do we do this? So we do this through providing them with that rapport of a person. We usually assign them a primary care coordinator who is either a social worker or a nurse, who kind of is the person who, if they haven't called us, we're seeking them out. But we work as a team, and so if they call in with a medication concern, we're coordinating with our pharmacist. If they're calling in with social concerns, if the nurse is the primary, we have our social worker help them. But our goal is to build, at that initial visit with the provider, some care guides. And that goes to all of our patients. And those are built around their healthcare conditions. And so if they have, hypertension, CHF, COPD, they get a care guide that helps to give them important phone numbers they need to contact, as well as information or symptoms that if they're having, they either need to seek emergency care or they should be contacting the care team, and then we would work through a plan with them. So they're a little bit more generic and vague, kind of give them some standards of care types of information in them as well. When we have a palliative care patient, we take that one step further and do what we call an urgency plan. The urgency plan philosophy came from the fact that the provider that was leading our palliative team really wasn't fond of order sets. And so we came up with this new solution, and we enlist our pharmacist to be a huge partner in this. And we go through symptom management. And so if, say, for instance, shortness of breath is a concern, we make an individualized plan for that patient. What works for them, what are some non-pharmacological things that are kind of standard, have you tried this, does it work? If not, these are maybe some things you could try in the future. And then we try to go one step beyond and look at some of the pharmacological things. So if they're having shortness of breath, they're having more sputum production, or it's purulent, or 2 of 3 symptoms, we'll just say, then the doctor will put an order in that's held at the pharmacy for, say, prednisone or doxycycline. And we as the nurse then can instruct our patient to start those medications. Once they start those medications, then we partner with them and say, can I call you tomorrow and just check in to see how you're doing? You need to call us if things worsen between then and now. And we, if they're getting better, then that's great. If they're not, then we would get them in to see their primary care provider and or coordinate with them, the provider, to see what the next steps would be. And so that's kind of how our urgency plans work. And I think we've talked a little bit about the phone calls. I jumped ahead. So next slide. All right.
So
that's Jen.
Hi. So we have sustained this program. In the beginning, we didn't know about chronic care management codes. And so like you said, as the basis of this audit was the right thing to do. There was probably several years where this was just the right thing to do, and that's what we knew. As everyone sort of started to figure out that care coordination and extending care extenders and those kinds of models started to appear, we started to find ways to make our work sustainable. So we currently use the chronic care management billing codes with our Medicare population, transitional care management codes for when they're coming out of the hospitals. My staff do all the callbacks from the hospitals that even patients who are coming out of tertiary care in the Twin Cities, coming back home, we call them so that we're within the range to be billing some of those transitional care management codes when they come back to our clinics, and so that our physicians have that connection to their patients. Jenny does an awesome job of keeping our callbacks after emergency room visits up to date. Every care coordinator attempts at least to call their patients if they've been in our emergency rooms, and those kinds of things they pay for themselves because our patients are being connected with after things are happening. We're getting ahead of things, and like you say, those are hard to measure. We are currently we will be in an ACO, I believe, in the next by January. So Jenny is the lead on that. We don't know a lot about what that means, but we do know that it works. This work that we do is important for that relationship. So that's a new piece of what we're doing here. We are exploring the integrated behavioral health codes and population management for mental health and substance use. We do have a Suboxone program that's also within our care coordination department, and most of those codes can be used to bill in that population of people. And then we are healthcare home certified, so our MA population, Jenny does the hearing, and then we are billing for that as well. So those are some of the ways that we've been able to sustain this work. And they're all new. They've probably all happened in the last 5 to 7 years. So when we started this work, we truly were doing it because it was the right thing to do. Is that it? I feel like we could talk forever. Yeah, I think we just really fell in love with this work when we started so long ago, and we're so thankful to Stratis Health for getting us where we have been and keeping us up to date of what new things we can try. And it's truly been an interesting, from a leadership perspective, it's been interesting to manage because this team really, what they know is change. So it's good change, but it's a lot of change in this world in the last decade, I would say. So if anything, what they are the masters of is doing the right thing for their patients and staying on top of another ball rolling at them. And I would say that the ACO is a whole new ball for us to figure out. So I want to I'm just really thankful for this team and their ability to do that. And great work. So thank you guys.
Thank you, Jennifer and Jenny. I have your contact information up, so they are fine with people asking questions. Thank you so much for telling us about your journey, ongoing journey at Wellia Health and your palliative care program. Our second set of panelists are from Avera Health, a large South Dakota-based health system that provides health care in many rural communities. Our speakers are Dr. Franny Arneson and Katie Huff. I'll introduce Dr. Arneson first, and then Katie. Dr. Arneson is board certified in hospice and palliative medicine and is currently the medical director of the palliative care medicine program at Avera McKinnon Hospital and University Health System. She has diverse responsibilities to help promote excellent care and delivery of palliative care services throughout the Avera Health System. Katie is a family nurse practitioner where she provides palliative care services in inpatient, outpatient, and long-term care settings. She also provides support to the Avera at Home Yankton Hospice Agency. Franny and Katie, I'll turn it over to you.
Great. Good afternoon. Thanks for including us. I guess I'll just start with a quick overview of the services that we offer in Sioux Falls. So Sioux Falls is our flagship hospital location. We have over 300 inpatient beds if you exclude pediatrics and OB and psychiatry. We do have a multi-state catch area. So we see inpatient consultations in the main hospital as well as in the heart hospital, which is a separate location. And then we have ambulatory clinic. One of our clinics is embedded in our cancer center that's right on our main campus. And we do approximately 7 half-days a week of clinic in our cancer center, and that has been very busy. And then we also have a freestanding clinic that sees all of our non-oncology patients. I'm actually a neurologist by training, and so I also run the interdisciplinary ALS clinic on our campus. Next slide. So our team here in Sioux Falls includes myself, another physician, 3 nurse practitioners, 2 social workers, 2 RNs, a clinic manager, and then a support specialist. We also have, as of probably the last 6-7 months, pharmacy that spends a good portion of the week right there in our office with us. And then we have chaplaincy support through the hospital team for our inpatient service. And then there's a dedicated chaplain at our cancer center that we can utilize for our cancer palliative care patients. Next slide. We are a referral-based service. You know, when we think about, I know at the CAPC seminar a couple weeks ago, they were talking about how, you know, the problem 10 years ago was how do we fill our service? How do we get patients? And anymore, it's services tend to be busting at the seams. And I think that that's been the problem we've had, if anything. So we haven't actually done marketing at all. In fact, we haven't even talked about seriously implementing triggers. The referrals that we get tend to be very appropriate, and our clinics are very full. Our inpatient service is very, very busy. And so right now we're, you know, thinking about how to grow in a way that's very intentional, that's meeting the need of the patients, but not outstripping our resources that we have on our team. Next slide. So like I said, we do hospital and clinic consultation, and I think of us as kind of a co-management model. We certainly are never primary on any of the patients. We like to work together alongside the other medical teams, and depending on the referring physician preference, we may make recommendations versus actually co-managing medications. In our outpatient cancer clinic, which I personally see most of those patients, I oftentimes will write scripts for and manage the medications for symptom management, working closely with oncology. And the inpatient service, we're never the ones that do discharge prescriptions or discharge summaries. We're generally making recommendations and putting in orders while they're inpatient if it's convenient to the referring doc. You know, we try to base our visits based off of the guidelines, right? So we're trying to do a symptom assessment, but then also making sure that we're touching on all of the different domains. So making sure that we're doing a detailed social, functional, spiritual, nutritional, cognitive assessment on every patient. That might not all be in one visit, but during our relationship, we try to make sure that we're touching on all of the domains and documenting that as such. We also include information and education about advanced care planning with all of our patients. We also have quite robust phone support for our clinic patients, certainly. Our nurses and social workers that help us with our clinic patients do frequent follow-ups. And then a lot of connection to community resources through our 2 social workers. They're amazing geniuses, and they help out a lot with handicap tags to referring to counseling and you name it. Next slide. So talking about financing and the sustainability of our program, I would say that anytime I'm meeting with C-suite folks, we definitely stress how important the mission is at Avera. We are a Catholic health ministry, and so serving the marginalized populations is of the utmost importance to our mission. And so clearly that aligns very closely with what palliative care focuses on. So we do stress that, and I think that our leadership finds great value in how that alignment is. We also focus a lot on having a very lean practice, really trying to always optimize how efficient and effective we are as individuals on teams. So we often don't do group visits. We kind of divide and conquer and try to do assessments, whoever's in the room first, as to what the patient needs from which team member, so we can be as effective and as efficient as possible. And then we also try to optimize patient support through a lot of phone calls, and then referrals to other support, counseling, integrative medicine, the interventional pain service, radiation, et cetera. We also do, though, with administrative folks, talk about our cost savings. We are involved in a couple ACOs as a health system, and so our leadership really does recognize the benefit, the value add that we have in terms of cost avoidance. And our program is supported through our hospital. Next slide, and I think we'll hand it over to Katie, who's in one of our smaller regional hospitals, and she can talk about how we've collaborated and tried to make our services consistent despite being in 2 very different communities.
Thank you, Franny. So thanks for having us. So as Franny mentioned, I work full-time in Yankton, which is a smaller regional facility through Avera. And so it was really exciting when we had the opportunity to work with, Dr. Arneson's group to really kind of mimic our model and kind of standardize the practice across the Avera footprint. And so our model in Yankton, while it's somewhat different in terms of kind of the locations of services that we provide palliative medicine services to our patients, our structure and kind of our model of care delivery aligns with the group in Sioux Falls. And so we were able to really capitalize on that and collaborate with that team. And so we kind of use the whole philosophy of let's not reinvent the wheel, let's practice evidence-based medicine and really try to make sure that we're following the national guidelines. So I work at a regional hospital. We have we are in a rural area, 100-bed inpatient bed facility, and we serve the southeastern part of South Dakota. We do kind of capture, we're right along the Nebraska border along the Missouri River, so we have patients from Nebraska and surrounding areas of Minnesota and Iowa as well. In our area here in Yankton, we also have a very large long-term care facility, 187 beds. And so when we developed our program, we identified that, certainly to be able to sustain a model of palliative medicine in solely just the inpatient setting was probably not realistic in terms of financial, looking at the financial pieces of that. And so we kind of did it actually in stepping stones. We started providing services on the inpatient side in our regional facility, but then we added services in our long-term care facility and provide on-site palliative care to our long-term care residents at our large nursing home here in town. And then to kind of take it a step further, then we added ambulatory clinic as well. And so our outpatient services in the ambulatory clinic are actually located within our Avera Cancer Institute that provides radiation oncology services in our region. And so there we do see oncology patients and non-oncology palliative medicine patients as well. You can go to the next slide. You can go to the next slide. So our team is made up of, right now we have 2 medical providers. Myself, I work full-time, and then we just recently added a board-certified palliative and hospice physician who is fellowship trained, and she is providing additional support to our team 1 day per week, seeing patients on the inpatient and then clinic side as well. We have one full-time nurse, and then we have 1 full-time social worker. We also have been blessed with the support from pharmacy, actually through the Sioux Falls Avera McKinnon facility, and they provide support to us remotely, kind of on an as-needed basis, and then meet with our team on a weekly basis to review and kind of triage high symptom burdened patients to look at medication management as well, but they're available to us on an as-needed basis in between those weekly visits. We also have chaplain support through our hospital chaplain services. So when we're seeing patients on the inpatient side, those chaplains typically attend, whether it's in conjunction on our initial visit with the provider or in follow-up. They will see all of our palliative medicine patients and follow up on spiritual concerns that they have. They also provide services out at our Avera long-term care facility here in Yankton. So the same chaplains that are on the inpatient side actually do long-term care as well. They will provide support on an as-needed basis to us in the ambulatory setting. However, we don't have a dedicated chaplain that's solely for palliative medicine at this time. We also do have a support specialist that is embedded within our ambulatory clinic that helps with some of our scheduling and phone call needs as well. You can go to the next slide. So sustainability, Franny kind of touched on this, our model and our, mission-driven model is certainly kind of the highlight of that, but we do also talk about the impact of our quality outcomes. So we when we're talking with administration and leaders, we're talking about the reduction in polypharmacy and the symptom management and improvement in quality of life that our patients are experiencing because of the services being provided. But we also talk about avoidance of hospital readmissions, and then we talk about impact of cost avoidance. So we track hospital days saved. We talk about avoidance of those readmissions, length of hospice stay for those patients that transition to hospice at some point, and then again avoidance of hospital admissions among our nursing home residents, which is a more specific population. You can go ahead and go to the next slide. Specifically in Yankton, we have had great support through our Avera Foundation, and I think we heard that in the initial presentation talking about some of the financial sustainability things. We certainly haven't relied solely upon the foundation support, but that has helped to offset some of our costs, and so they've actually done some fundraising for our program for the initial startup, and as we're expanding our services. We too, as Dr. Arneson described, have been kind of busting at the seams in terms of capacity and patients, so really looking at maximizing our team skills. So we have a dedicated nurse that really helps to kind of man the fort out at our long-term care facility and helps to triage patient needs in between provider visits. So really capitalizing on all of our team's skills. Also looking at sustainability, we really looked at that blended model, looking at inpatient, ambulatory, and the long-term care model, knowing that in the rural area, solely focusing on inpatient referrals probably wasn't going to be a real sustainable model, so the blended model has really worked well for us. We also recently, in our smaller ICU in our regional facility, have implemented a project with our ICU staff to promote earlier referrals. We were finding kind of in the startup of our program that we were getting a lot of late referrals in the ICU setting. And so there's been a standardized palliative care screening tool that's been implemented into the EMR to promote identification of unmet palliative care needs within the ICU setting. So that's been a great added resource, and we're seeing great results with that as well. I think that's it for me.
All right. Well, thank you so much, Dr. Arneson and Katie, for sharing your story. And now we have the time for questions. I noticed that we have about 4 or so questions in the chat. So if you have questions when you're on the computer, just put them in the chat. And then if we have time, we'll have the folks that are only on the phone have an opportunity. So the first one is from Lynn Reinke. She wants to know, do either programs use or plan to use community health workers in the home?
From Wellia's, we don't have a plan to include them in 2020, but we have definitely learned about them and understand the value that they can add to a program. At one of the MDH learning conferences we attended, I attended a breakout on them and hear a lot of really positive feedback. It would probably work well for us in the future.
Okay, thanks, Jen. Anything from Avera Community Health Workers for you guys?
This is Katie. We currently don't have a plan in place to add community health workers. However, we do collaborate very closely with like our skilled and unskilled home health services. So we make a lot of referrals to our home health agency, and then when appropriate, if in line with patients' goals of care and overall prognosis, and kind of depending on the patient scenario, we work closely with hospice when that's appropriate. But we do collaborate quite a bit with our local skilled and unskilled home health agencies.
Okay, thank you. Yeah, it's a great concept using community health workers. And there have been some studies done on them as well. Okay, the next question comes from Katie. She asks, are the chronic care management codes that are used provider billing codes?
This is Carla.
I can answer this, I guess. When we bill in clinic, we are billing, I generally bill based on an E&M code for depending on medical complexity and what I completed in the visit. And then I oftentimes will use, if we do any advanced care planning, I will tack on an advanced care planning code as well. And so usually it's a combination of those two for both new and follow-up visits.
This is Katie, and I would concur with that. That's the same way that we currently bill.
And there's a bunch of resources linked in the guide that we had a link to that kind of talks you through those codes and how to use them.
Thanks, Carla. Jenny, did you have another comment?
I was just going to say that, we bill for the chronic care management codes strictly with the work of the nurse or the social worker. And it's a provider-based, it's through their provider that it's billed out, but it's work that can be done by other staff that doesn't require a physician or a provider's license.
Okay, great. Just somebody would like an explanation of what inpatient palliative care, how they work, inpatient palliative care services, how do they work? Probably you, Franny.
Sure. This could be a whole hour-long lecture in and of itself, but generally, if a referral comes in, it's triaged by our support specialist, and then it goes to either a nurse or social worker to look at it. They figure out who's up for the next new consultation, which billable person, so a nurse practitioner, a physician, whoever's covering the inpatient service that day, and then that person would review the chart, call the referring team and any other key stakeholders. So if it's an oncology patient, they'd call the primary oncologist as well, just to make sure the question's clarified, what we can actually help with, and that we understand what they're thinking about the case before we go introduce ourselves. And then it depends on the workflow of the day. Sometimes it might be one of our nurses or social workers that go in initially to do an assessment, get to know the patient and the family, build a rapport, and, you know, figure out what are the highest needs medically. And then, you know, the APP or physician would go and, you know, really talk through the medical piece. So make any symptom management recommendations. And usually it's the physician or APP that are doing the bulk of the goals of care conversations if it's a big old family meeting, or they're at least present for that. You know, the social worker might be the one kind of leading the discussion. And then, you know, we would, based on our conversation, we would document our recommendations and our assessment and plan. And then we would usually close the loop on the back end, making sure that whoever referred the patient to us, that we communicate what our recommendations are, whether we're putting in the orders or we're recommending that they do. And then we also talk with the bedside nurse and case management social work on the floor, because they oftentimes are waiting for us to come see the patient to see if it's going to change dispo or what have you. And then, you know, we do follow up based on our what we as a team feel is medically necessary. So it may be that if it's a symptom management patient that our nurse follows up the next day, and if things are stable, we might not have a physician or other provider see the patient that following day, or if things need to be adjusted, then somebody would go by and assess, make adjustments. It might be that they're not having a lot of symptom burden, so it would just be a social worker going by to follow up for family or patient support. Does that answer the question?
I think that's great.
Okay.
An hour, you did it like 2 minutes in an hour, or
Okay.
an hour's worth in 2 minutes. So I see our time is up, and there are a lot of great questions in the chat. What I'd like to do is just copy those off and send them to our speakers, and then send them out to all that registered. Are you speakers okay with answering some questions that we transmit by email?
Of course.
You bet.
Okay, great. So this concludes the educational session for today. Thank you, everybody, for attending and your participation. Special thank you to our speakers and the great work you're doing in bringing palliative care to the people you serve in rural communities. So please complete the short evaluation survey that will be in the chat here shortly, and in an email that will come from Jody. Print out your certificate and forward the email on to anyone else that participated with you. So this session was recorded and will be available on the Stratis Health Palliative Care webpage in about 2 weeks. Thanks, everybody, and have a great rest of the afternoon.
Thank you. You